Hi, my name is Enrique Castro Sánchez, and I will be talking to you about the involvement of nurses in antimicrobial stewardship, an essential component towards the COVID-19 response, and many more things. So first of all, my declaration of interest. This talk is simply my opinion, so any mistake I make is just mine and not anything to do with my employers, which are listed there, including some honorary positions. I have to admit that I have been funded by the Florence Nightingale Foundation, Imperial College, and others to learn about how nurses take part in antimicrobial stewardship interventions. And finally, I suppose that this talk simply represents my view as a nurse, but as a nurse who's involved in many aspects of nursing, such as clinical work, research, teaching, leadership, and patient advocacy. And of course, it reflects the points of view I have as a specialist, as a consultant, as a prescriber, and so on. Of course, I also give you some informed consent. I'm delighted to see the presentation shared on social media and use it during any educational activities. And of course, I'm really happy to discuss ideas. Happy to be told I'm wrong. Happy to ask to collaborate either in the real world or on social media. So I think it will be important to reflect upon some of the challenges that we have ahead in terms of increasing the participation of a more diverse healthcare workforce against antimicrobial resistance. For example, we have got key documents such as the review on antimicrobial resistance, asking for and advocating for governments, healthcare system leaders, and private actors to expand the funding and the opportunities and essentially increase the number of healthcare workers engaged in antimicrobial stewardship interventions against antimicrobial resistance. And I don't think anyone can argue against that idea. I think it kind of makes sense. However, on the other hand, we have to try to address some challenges and realities. By 2035, the WHO estimates that we will be just short under 30 million healthcare workers. So we really need to come up with some way of increasing the contribution of the workforce and, however, try to address that gap in terms of the actual number of resources available. So I suppose that for me, it would be important to think about how the existing workforce can increase their contribution towards antimicrobial stewardship interventions. And particularly, I'm thinking about how nurses can increase their contribution, considering that they are the largest healthcare workforce worldwide. In this figure from the World Health Organization, you can see the ratio of nurses and midwives versus the number of physicians around the world, and the darker the color in the country, suggesting that the higher the number of nurses and midwives and the fewer doctors are available in the country. So you can see, first of all, the striking and starking differences in the healthcare workforce composition. But just to give you an idea and to give you some context of that difference between doctors, nurses, and midwives, in the UK, we have got about 150,000 doctors and just under 380,000 nurses. In the US, for example, we have got, or there are about 4 million registered nurses, whilst in India, there are about 3 million nursing personnel, because of the figure includes nurses and midwives and equivalent healthcare workers in the community. Now think for a second, if we were able to increase the contribution of 1% of such existing workforce, increase just by 1% as well towards antimicrobial stewardship interventions, and how much better and how much more cohesive and powerful the fight against antimicrobial resistance may be. Now, such calls for a widened participation in antimicrobial stewardship interventions of a wider, a more diverse workforce are not new. You already can see here how in this paper, Dr. Smita Sharani and Professor Alison Holmes from Imperial College advocate for the use of existing systems and structures, including existing healthcare workforce cadres. And more recent views incorporate or ask for the incorporation of other members of the interprofessional teams, such as specialist nurses and, for example, infection prevention and control nurses. So their incorporation into existing or antimicrobial stewardship teams in what I call antimicrobial stewardship 2.0, and as advocated by Professor Nathwani. Again, it does make sense to increase such contribution, and I don't think, again, that anyone can be against the idea. However, on the other hand, that engagement has to be supported, and more importantly, it has to be allowed. And again, in the paper from Rachel Edwards, a colleague at Imperial College, about a decade ago, already there was a painful idea about how the omission of nurses from the decision-making process, and I find that idea particularly interesting, that we're not calling for an omission, or we're not noticing an omission of nurses from the clinical delivery of antimicrobials, but the decision-making processes regarding antimicrobial therapy has limited the extent to which nurses may influence outcomes. But nurses must embrace this responsibility as well. And in order to do that, and even before that, it is necessary to design and develop appropriate metrics that quantify the impact that nurses and nursing can have towards antimicrobial stewardship interventions. Equally, it is necessary to incentivize hospitals and other healthcare organizations to address and mitigate the lack of commitment of nurses with stewardship. These 2 points are raised in, for example, the white paper by the CDC and the American Nurses Association working group towards the contribution of nurses in antimicrobial stewardship interventions. But I think, on the other hand, that these two, and certainly the lack of commitment of nurses with stewardship, could respond to the limited education that we have seen before. It is as well fair to say that up until now, most of the contribution of nurses towards stewardship has really focused on the clinical aspects and the clinical domains. As you can see here in this paper from the Olans in CID, they catalog a series of activities with functions related to antimicrobial stewardship. And of course, all of them are right, but clearly they just focus on the clinical aspects and clinical domains. And it is essential and important that nurses are efficient and optimal in those areas. However, other pieces of work have highlighted how, in addition to the clinical role and the clinical activities, the nurses and nursing can contribute in several other domains, including advocacy for patients and communicating with relatives and families and so on. But again, the majority of our contribution has been advocated as within the clinical sphere. It's only recently that some papers start to suggest how nurses can develop roles that are non-clinical, but that they are crucial towards the success of antimicrobial stewardship interventions. For example, in this paper, you can see how there are some suggestions and recommended actions to the, for example, American Academy of Nursing, focused on policy, and as well the National Institute of Nursing Research in terms of research. So as nurses, we have got many more domains that are, in addition to the clinical one, in research, policy making, management, leadership, and education. So it is not really appropriate to just focus our contribution on the clinical aspect. Thinking again about the clinical aspect, actually, it is really fascinating to think about how, for example, in Scotland, Scottish community nurses will prescribe more antibiotics soon than hospital doctors, if you believe in that 80% of antimicrobials are prescribed in the community. And in this report from the National Health Service in Scotland a few years back already, how nurses were responsible for just under 6% of that 80% of antimicrobials prescribed. So, soon nurses will contribute much more to the volume of antimicrobial prescriptions than other professionals. It is, of course, quite nice to see evidence that suggests that nurses are able to prescribe appropriately, and that also they're able to, when they don't prescribe antimicrobials, satisfy and meet the needs of patients who end up consultations feeling still heard of and attended to without receiving an antimicrobial. This is just a focus on the UK, of course, and in many countries around the world, I cannot forget and to stress the contribution towards healthcare and healthcare delivery that many nurses have. In this case, I was really fortunate to be able to visit Euphrasi in Rwanda, a nurse leader who runs her own health post in Rwanda, and of course, you know, how she's able to manage not just infections and common infections, but more complex infections such as HIV and tuberculosis, which require the prescription of you know, powerful compounds. So in order to increase the participation of nurses in antimicrobial stewardship interventions, I believe that we've got 4 key barriers to resolve and to address. The first one is what I call the foundational barrier. If we were to ask nurses whether they think they should do antimicrobial stewardship, the answer would be most likely not really. And we already have got some evidence that suggests that in comparison with other professional, nurses are much less likely to have heard about antimicrobial stewardship. And more importantly, they're much less willing to participate in antimicrobial stewardship interventions. In this paper, I have to admit I was quite pleased to see that we were not that far away from other professionals such as surgeons in terms of their willingness to participate in antimicrobial stewardship interventions. Another barrier that has to be resolved, in my opinion, is the barrier of ownership and branding. And by this, I mean that if we were to ask nurses whether they actually do antimicrobial stewardship, they may say, okay, I'm not sure, maybe we do that, which is very interesting because when we have carried out studies asking nurses which of the typical antimicrobial stewardship interventions they carry out, a striking number of nurses reported carrying out many of those interventions. So in this paper from Bulabula et al., asking managers and nurses across Africa how many of these interventions they perform daily, you can see how, okay, around 40% of nurses reminded prescribers to review antimicrobials. But, and again, you know, another 40% of nurses reminded prescribers to review the need for devices. But more interestingly, about 60% of nurses taught about appropriate use of antimicrobials. Just over 50% of nurses led or took part in audits and data collection on antimicrobial usage. And, you know, over 40% of them were members of committees making decisions about AMS or ensure that the doses of antimicrobials were administered at the right time. So I think it's important to remember that maybe if we're asking nurses about AMS, they will not recognize the brand, but if we were to ask nurses about what is it that they do that could be related to AMS, the proportion of them engaging in those activities may be reported as much higher. Then again, in my opinion, and these are the components of START, SMART, then FOCUS, you know, this is, in my opinion, not antimicrobial stewardship. This is essential nursing care. So ensuring that antimicrobials are administered on time is not AMS, it's essential nursing care. Adopting the necessary infection prevention and control measures is not AMS, it's optimal and essential nursing care. And reviewing the treatments that you administer to your patients daily is not AMS, it's essential nursing care. So it is important to bear this in mind, because often nurses will tell us, hang on, now you are asking me to engage with once another type of intervention in addition to everything I have to do. I am really busy and I don't have time. And you can see that all these components, all these interventions, we think they're optimal package of stewardship. They're not additional interventions to essential nursing care. They are actually essential nursing care. And equally, what I'm showing you here in this paper, reporting on the amount of medication that is actually not, the amount of antibiotics that are actually not administered to patients because they are left in the IV giving set. In my opinion, this is not poor AMS, but it's poor nursing care when you're not actually administering to your patient the required medications. So again, it is possible to address these concerns about increased workloads by simply highlighting that we are already engaging in AMS simply by performing nursing care well. But it is fair to see the point of view of really busy healthcare professionals who may not have all the resources, human and material resources that they would wish to have, and that they are concerned about the quality of the care they deliver. And therefore, it may be that the messages that we have to put out there as leaders and managers of healthcare services are not about, you have to do this because this is important to your patient. It may be that whilst that is the case, what we have to do is tailor the messages and the narratives to the different mindsets that are typical of the different healthcare workers. So, for example, thinking about prescribing antimicrobials appropriately, was it would be perfectly fine to say to a prescriber that antibiotics need to be checked. On the other hand, for nurses, the messaging may be much better if it's tailored about, appropriate antibiotic prescribing shows our potential, thinking about nurse prescribers, or caring for our patients means checking that the antibiotic is appropriate. So we're not talking about challenging others. We're just saying that because I value the safety of my patient more than anything, I will check that their prescription is correct. Thinking as well the potential for the existing synergies that could contribute towards developing new nursing roles and programs in stewardship. The central role of infection prevention and control, a discipline traditionally led by nurses, will lend a really exciting hand to the development of antimicrobial stewardship roles in terms of nursing. But again, in many other settings and in many other countries around the world, it may be more relevant to tag along AMS roles to TB HIV specialist nurses, or patient safety specialists, or community engagement nurses. But I think that this slide, I just wanted to show you the potential to act in synergy, and of course, without forgetting that there may be many activities and actions that are the responsibility of the classically trained pharmacists, doctors and pharmacists. So if you're thinking about developing new roles for nurses, it may not be necessary for you to carve a specific actions, interventions and roles for these professionals, but it may be that we just need to strengthen the contribution to the common pool of responsibilities that are important in AMS. Thinking about some of the existing evidence about existing AMS roles for nurses, in this paper in the UK, we sort of sampled the variety of roles across the country of nurses working in AMS. So you can see how you have got a variety of strategic influences and relation with different structures. We also identified several individual identities. So many of the nurses working within AMS were staff nurses, but some others were advanced nurse practitioners or advanced clinical practitioners now. Thinking about the funding and managerial structures, there was also quite a variety of sources of funding, and of course, managerial structures and settings of practice, as well as the role components. So thinking about the beginning of the presentation, where much of the AMS responsibilities were focused on the clinical domain, these analysis of roles demonstrated that nurses also engage in education, policy making, and quality improvement. And overall, it's possible to think about the different roles as articulated around three different models. The vertical model, something like a nurse consultant, who would have a high level of strategic influence, may not have that much level of sort of clinical impact or direct clinical impact. Hybrid models, something like a nurse specialist where there is some strategic influence, but much more clinical impact. And it is really easy to attribute improvements related to the introduction of this role. And finally, it's possible to think about models which are much more horizontal, where all nurses have got slightly increased roles and activities related to AMS. And this paper, I think, is important because it simply tries to demonstrate the variety of options that we've got available as leaders when thinking about deploying increased AMS nursing roles. Some of the evidence that exists where interventions have been put in place once the landscape of the contribution of nurses has been explored. Some of this evidence presented here that's available for you has, for example, focused on adapting capability, opportunity, and motivation frameworks to facilitate the promotion of intravenous to oral switches, for example, and how some other papers identify the barriers and facilitators for the development and the implementation of nursing roles. It's also particularly sad to think about that nurses don't really consider that they do AMS, because when we implement interventions that improve the knowledge and enhance the skills that nurses already have, we see marked improvements in clinical outcomes related to antimicrobial use. And of course, that we see, for example, an increased proportion of patients for whom nurses discuss antibiotics during ward rounds, and there are overall improvements in outcomes related to antimicrobial use. Another barrier that needs to be resolved is the educational barrier. So if we were to ask nurses whether they know what to do in AMS, probably the answer would be that not really. They don't really know what their role would be. And that may not be that surprising considering some of the evidence that we have regarding undergraduate educational programs, particularly for nurses. So in this paper in +1, we reported on the content related to AMS delivered in undergraduate university courses in nursing, medicine, pharmacy, dentistry, and veterinary medicine. So we focus on all the components of AMS, and we ask all universities around the UK to tell us what were they teaching, in addition to a few other details about how the education was delivered and who was delivering such education. But you can already see here how, thinking about nurses, the sort of dark green line, fewer nursing schools compared with the other healthcare professions, first of all, delivered all the components of AMS, so around 11 to 13% of courses included all the content. And again, more strikingly compared with other professions, how some of the components were hardly taught. So for example, just a handful of courses included the single-dose surgical prophylaxis, education about that, as well as the need to review broad spectrum of antibiotics, and so on. So it's not surprising then that if nurses are not really equipped with education about these components and these aspects of antimicrobial stewardship interventions, that then they cannot really participate and they cannot really engage and lead them. These findings from the UK have been, in a way, replicated in other settings. And in this paper, recent paper from the US, you can see how only around 14% of our nurses were perceived to have adequate antimicrobial stewardship knowledge to participate in activities, with another 24% of them just reporting as having a neutral knowledge. So it's difficult to engage, and it's difficult to participate and even lead in educational, clinical interventions when we don't have the undergraduate knowledge, we don't have the skills, we don't have the education to do so. And thinking about education as well, it is striking to notice the differences between the different qualifications. So for nurses in that particular paper in Merrill et al., you can see how nurses who had a BSc, who had a degree, were much more likely to know and much more likely to participate in antimicrobial stewardship interventions compared with nurses without a degree. Again, asking and reminding us for the need to tailor educational interventions and tailor interventions in general to the workforce that's available in every healthcare setting and in every healthcare system. In the UK, thinking about interventions to mitigate and address those gaps. For example, we have got the full report from Health Education England following the findings of our paper a few years back, where they raised awareness and they asked educational institutions in the UK to consider how best incorporate all the components of AMS in the different healthcare undergraduate curricula. And again, for me as a nurse, I think it's fantastic to see how in a few years we've been able to move from simply highlighting a gap in the educational content in university to the latest code of conduct for the Nursing and Midwifery Council, the regulatory body for nurses in the UK, where one of the key elements that nurses have to demonstrate in order to be able to be seen and see as nurses, to register as a nurse, is the need to protect health through, of course, an understanding and application of the principles of infection prevention and control and antimicrobial stewardship and resistance. So this is the first time in the history of the Nursing and Midwifery Council Code of Conduct and the requirements for nurses that antimicrobial stewardship appears. In order to support those educational domains, we have been working in collaboration with Professor Courtney in Cardiff. We have been working to develop competencies for nurses and other healthcare workers, to be fair. Not just about prescribing antimicrobials, for which you've got plenty of other competencies, but all the necessary skills and knowledge and attitudes that are required to engage in the decisions about antimicrobial use. So anything from, of course, knowing about infection prevention and control and describing, for example, how microbiology samples may aid the diagnosis of infection. But for me, one of the more crucial domains is that one about interprofessional and collaborative practice. So how to practice effectively as a nurse in a team of other healthcare professionals, working with other healthcare professionals to deliver top quality care. At a global scale, more recent documents such as the WHO Competency Framework for Health Workers Education and Training, on AMR, incorporates again specific domains for nurses. And what I like about this document is that many of the specific competencies for nurses are also competencies that are reflected in other professions. So again, bringing a sense that although each profession has got sometimes a particular kind of intervention in decisions about antimicrobial usage, all professions have to have a strong core of common competencies related to decisions and use. But it is important to think about how nursing and nurses and knowledge are not really static. And by this, I mean that, for example, in the UK, we have recently created a new profession, a new nursing associate profession that bridges the gap between nurses and nursing assistants. And it is important to remember that these professionals will deliver medication, including antibiotics, and therefore will have to engage with patients about side effects and about effectiveness of this medication, and they will have to pass information about the effectiveness of the therapy to other colleagues. So they have to have the knowledge, the skills, and the attitudes that will be effective to collaborate with others. Equally, in other settings around the world, we have got many more professions, many more types of healthcare deliverers, in addition to the classically trained and formally trained doctors, pharmacists, and nurses. So in this paper from a low-income setting, you can see here how they've got auxiliary nurse midwives and they've got lady health visitors, and all of them will be engaged in the decisions to use antimicrobials, either when they discuss health problems with patients or when they report back in the health centers and so on. So it is important to think about how do we keep knowledge fresh for the different professions that may be appearing. And it may be that it is necessary to develop and maintain nurse-specific resources, and that this may help. And in here, I've put a selection of those resources, anything from the first antimicrobial stewardship for nursing practice book to guidelines and publications from the European Specialist Nurses Organization to specific chapters for nurses in the ebook published by the BISAC in the UK. So again, resources that include tailored knowledge and skills for nurses. Other resources which may have nurse-specific content include MOOCs, such as the Antimicrobial Stewardship Managing Antibiotic Resistance by, again, the University of Dundee and BISAC. Other kinds of resources that may support nurses' activity related to AMR include, for example, interventions such as this one, which I absolutely love because of the simplicity and the elegance of it. So can dialogue support help? Developing scripts like movie scripts which can be used by nurses to start conversations about the need to switch therapy or to pass information to prescribers about the progress or lack of progress related to antibiotics. So nurses were telling us that they didn't really know how to start the conversation. So in this particular paper, they report on these scripts that truly help nurses start the conversation. And you can see that the scripts are not particularly complex or difficult, and they may look simplistic or be seen as simple, but they are effective because they bridge that gap, and they're able to help nurses, for example, dialogue with prescribers about, some results are back from the lab, the culture is positive for a given microorganism, and these are the susceptibilities of that microorganism. Do you want to continue with these antibiotics? So again, moving away from certain views about nurses challenging inappropriate prescriptions or challenging prescriptions that are too long, and thinking about how difficult it may be to say to people who don't have a particularly strong background, educational background related to AMR, as we've seen with that data from the UK and elsewhere. So we say to these professionals, you're going to have to challenge others who have got more knowledge a priori, and that they are in positions of higher power as traditionally seen, and for which there are maybe gender imbalances in many healthcare systems around the world. So I think that interventions such as these ones are particularly exciting and can be really useful. Other more niche interventions include technology-based ones, such as this virtual prescribing experience, Onqual Antibiotics, a product developed at in Imperial College, where in order to teach behaviors, so this is not about teaching which drug will address which bugs. These interventions help nurses and other healthcare professionals, of course, engage in the different behaviors that are relevant to decisions about antibiotic, getting immediate feedback, and so on. More advanced prototypes, such as this virtual reality-based collaboration between researchers at Imperial College and Coventry University, and this is a prototype, try to train healthcare professionals, including nurses, to be respondent to some of the challenges that they assume they will have when they, for example, have to negotiate antimicrobial prescriptions that may not be appropriate for a patient who is demanding them. So again, thinking about that scenario where patients are felt to be demanding, and how can we train nurses, particularly in many settings around the world where they are prescribing a noticeable volume of antimicrobial prescriptions. So these are more advanced products. And again, if you're thinking about this is not something that will happen in my patch anytime soon. Google Cardboard had these visors for about $5, £3.50, where any sort of typical Android phone could deliver this virtual reality intervention. So think about the potential for these technology-based tools. The final barrier to resolve is the leadership barrier, and how we need to increase the leadership of nurses in AMS interventions and programs, but also to increase the interest of nursing leaders about antimicrobial resistance. It's interesting that, for example, some policy documents may not really place the participation of nurses in AMS and use of antibiotics high enough, in my opinion. So in yellow, you've got the content that's included or was included in the European Commission's policy and guideline for the use of antimicrobials in adults in the European Union. So a key document from 3 or 4 years back that really presented a view of the participation of nurses in antimicrobial use as very clinically oriented and bedside focused. So we found we had to send a letter or address a letter to the European Commission asking them to consider an increased participation of nurses in several steps of the decision making related to antibiotics, and of course asking them to recognize the variety of roles that we've got already in many countries around the world, or in the EU in that sense. Interventions and activities that can help to increase such leadership include networking. So encouraging nurses with an interest and a role in antimicrobial stewardship initiatives to come together and think about how they can work in synergy and how they can enhance the work of each other. I was very fortunate to be in the Infection Control Africa Network Congress a few years back, and it was fascinating to see the level of activity and the kind of activities that many nurses around Africa and around the world were already carrying out in relation to antimicrobial stewardship and interventions. In the UK, I was very happy to be able to organize the first International Nursing Summit on Antimicrobial Stewardship, again, bringing together nurses and other healthcare professionals interested in developing joint roles and key roles about antimicrobial stewardship. So again, you can see a handful of people a few years ago interested in this domain of practice, which has been boosted by, for example, the development of this forum supported by BISAC, where all nurses around the UK working in antimicrobial stewardship with an interest in antimicrobial stewardship, they can come together and discuss and debate interventions and initiatives. Of course, in 2020, although it has been a slightly peculiar 2020, we cannot forget from the point of view how we should embrace the political opportunity afforded by initiatives such as Nursing Now. And again, thinking about how this increased contribution of nurses to delivery of healthcare services, focus on infection and appropriate use of antibiotic, at the end it's a political decision, and nurses also have to enact some political leadership that enables an increased contribution of nurses in AMS. I hope that over the last few minutes I've managed to give you some ideas and good reflections about nursing and AMS. To sum up, of course, antimicrobial stewardship programs must consider interdisciplinary participation, and that maybe around the world nurse participation is clinically oriented, but that may mean that it's underused in many other domains related to AMS. However, I will end with a note of caution. Before thinking about expanding current interventions or starting any current intervention that includes nurses, the underlying organizational determinants, how organizations are built, the conditions that are there to support or hinder the participation of nurses in AMS has to be explored. I thank you for your time. I'm Dr. Enrique Castro Sánchez, and you can find me on social media. Thank you ever so much.